Okay, let's unpack this. We know that ophthalmology, especially when you're trying to condense it down for the applied knowledge test, uh, it can feel like one of those really high-stakes black boxes.
It really can.
And for you, as GP trainees listening, the goal isn't really to become an eye specialist overnight. It's much more about mastering that initial triage.
Absolutely.
It's about being able to confidently look into a red eye and know pretty quickly, does this patient need shipping off to hospital right now? Or, do they just need a simple leaflet and some reassurance?
And that ability to differentiate, the completely benign from the potentially sight-threatening, that's exactly what we're drilling down into today.
Yeah.
So welcome, everyone, to part one of our Essential Ophthalmology Deep Dive.
Yeah, welcome.
Today, we're focusing pretty much entirely on the anterior segment. So that's the eyelids, the conjunctiva, the cornea, and those critical acute conditions like glaucoma and uveitis. We're basically taking the source material, pulling out those core clinical nuggets, and framing them specifically with AKT preparation in mind.
Right. Our mission here is really clarity. We need you to internalize the red flags, get comfortable with the basic tools, and honestly, get those 5 types of conjunctivitis absolutely straight in your head. Because let's face it, that is the bread and butter of eye stuff in primary care.
It absolutely is.
So let's start right at the foundation, the basics of assessment. We really have to begin with the basic pharmaceutical tools, specifically those drops that manipulate the pupil size. This distinction isn't just like academic knowledge. It's fundamental for diagnosis and, crucially, for managing patients safely.
Definitely.
So the first major distinction is miotic versus mydriatic.
That's the starting line, as you say, for both safety and diagnosis. So a miotic drug and the C in miotic can maybe help you remember constriction. It forces the pupil to constrict, to get smaller. The classic example you'll see is pilocarpine. Conversely, a mydriatic drug, something like tropicamide, which is very common, causes pupillary dilation, makes the pupil bigger. And this is something we do deliberately. It's necessary when we need to get a good look at the posterior structures of the eye, like the retina and the optic disc.
But the immediate clinical relevance of those mydriatic drops is huge, isn't it? Especially in a primary care setting where you might actually use them yourself for fundoscopy. What is that single non-negotiable safety warning you must give the patient? It's also, an extremely high yield point for the AKT.
Okay, the non-negotiable warning is simple, but it is absolutely mandatory. If you use a mydriatic drop, like tropicamide, the patient must not drive for the next usually around 3 to 4 hours.
3 to 4 hours.
Yeah, their vision will be impaired. They'll likely experience blurred near vision and often quite severe sensitivity to light photophobia until that effect wears off. And if you don't document giving that warning, well, you're risking patient safety and, frankly, medical legally, you're exposed.
It's an easy clinical point to just forget in the moment, isn't it? But so critical for the exam and for practice.
Absolutely critical.
Okay, let's talk about diagnosis itself then. Loads of conditions start right at the surface, and that's exactly why we need fluorescein. This often cited technique, it sounds simple: orange drops, blue light, but what exactly is it telling us about the state of the eye?
Fluorescein is, well, it's indispensable for surface issues. It's an orange dye. Usually it comes on a little paper strip, actually.
Yeah, basically.
You just touch the strip gently to the inside of the lower lid, and that introduces the dye into the tear film. Then, when you view the eye under a blue light specifically, you need a cobalt blue filter, which most direct ophthalmoscopes have.
Right.
The dye instantly highlights any areas where the corneal epithelium, the very top layer of the cornea, is damaged or missing.
So we're looking for that bright, almost luminous green staining.
Exactly that. That vivid green stain means there's a defect. It's how we spot things like corneal abrasions, where the epithelial layer has been scraped off, maybe by a fingernail or a contact lens. It's also key for identifying dendritic ulcers, those branching patterns you see with herpes simplex keratitis.
Oh, great.
And it's also essential for confirming if, say, a tiny foreign body, maybe under the eyelid, has left a scratch mark, sometimes called a track sign, as it moves across the cornea with blinking. This simple procedure is basically the litmus test for corneal integrity.
Okay, crucial tool. Now, let's turn to the sort of objective measurement of sight itself. Distance vision using the Snellen chart. We all know we document vision in formats like 612 or 660, the top number being the testing distance, usually 6 meters. And the bottom number is the distance at which someone with normal 66 vision could read that same line. But what happens if the patient literally can't even read the biggest letter on the chart? How do we proceed then? How to document that?
Yeah, this structured hierarchy is really key for documenting the true severity of vision loss. When the acuity is very poor and the patient can't read that top letter on the chart, we have to transition to these more objective functional tests. The first step down is usually finger counting.
Okay.
So you literally hold up fingers at different distances, say 1 meter, 2 meters, and record the furthest distance at which they can accurately count them. If they can't even do that, the next step down is hand movements.
Just waving your hand.
Pretty much. Can they discern the movement of your hand right in front of their face? Document the distance again, maybe HM at 1 meter. And if even that fails, the absolute lowest level of vision we can record is light perception, or PL.
So can they just tell if a bright light, like from your ophthalmoscope, is switched on or off?
Exactly. You ask, is the light on or off? And then below that is no perception of light, MPL, which is total blindness.
That structured descent Snellen chart, then counting fingers, then hand movements, then light perception. It's so crucial because it properly quantifies the degree of vision impairment. And that quantification directly dictates the urgency of your referral, doesn't it?
Absolutely. It standardizes the documentation. Just writing acuity poor in the notes is pretty meaningless clinically. Saying vision is hand movements only in the right eye. That's a clear, objective clinical emergency signal. Everyone knows what that means.
Got it. Okay, before we move off-site completely, let's just quickly clarify refractive errors. These are super common, usually benign, but the lens terminology for correction often trips people up in exams. Let's just confirm myopia versus hypermetropia and the required lens type for each.
Yeah, good idea. The easiest way is to think about where the light is focusing relative to the retina. In myopia, which is short-sightedness, the light focuses in front of the retina.
So they see near things okay, but distant things are blurry.
Precisely. To pull that focal point further back onto the retina where it belongs, they need a lens that diverges light rays. That's a concave lens, sometimes called a minus lens.
Okay, concave for myopia, and hypermetropia is just the opposite then.
Exactly the opposite. In hypermetropia, or long-sightedness, the light naturally focuses behind the retina. They often struggle more with near objects initially, though it can affect distance too. To push that focal point forward, onto the retina, they require a lens that converges light. That's a convex lens, or a plus lens.
Convex for hypermetropia. Got it. And finally, the other common one is astigmatism. What's the simple definition there?
Astigmatism is basically just an abnormal curvature, usually of the cornea, but sometimes the lens. Instead of being perfectly spherical like a football, it's shaped more like a rugby ball.
Ah, okay.
This causes light to focus at multiple points rather than a single sharp point, leading to blurry or distorted vision at pretty much any distance. It requires specialized cylindrical lenses for correction, often combined with correction for myopia or hypermetropia.
Okay, so if we sort of connect this whole foundational section back to the bigger picture of triage, the ability to quickly assess vision loss using that Snellen hierarchy down to light perception if needed, and checking the integrity of the cornea using fluorescein, those feel like the two absolute non-negotiable first steps, right? If vision is significantly affected, or if that cornea stains green, you're almost immediately bypassing the probably benign category and pivoting straight towards urgency.
That is the core triage model, exactly.
Yeah.
Most benign conditions might cause discomfort, redness, maybe some discharge, but they rarely, if ever, threaten central vision acutely or damage the cornea significantly. Any serious disruption to visual acuity, VA, or positive fluorescein stain immediately elevates the risk profile. You have to think differently.
Right. Let's dive into the red eye itself. This is arguably the most common ophthalmic presentation you'll see in primary care, isn't it?
Oh, absolutely. Day in, day out.
So to manage it effectively, we absolutely need to be able to distinguish that simple inflammation conjunctivitis from the true emergencies that can look similar initially.
Definitely. So conjunctivitis, by definition, is inflammation just the conjunctiva, that thin, transparent membrane covering the white part of the eye, the sclera, and lining the inner surface of the eyelids. Now, the moment that inflammation extends into the cornea itself, it becomes keratoconjunctivitis.
And that's immediately more serious.
It immediately elevates the potential severity, yes, simply because the cornea is essential for clear vision.
Yeah.
Any inflammation or damage there can potentially scar and affect sight permanently.
Okay. So when that patient with a red eye walks in, what simple question about their subjective symptoms gives you the greatest initial reassurance that you might just be dealing with a simple conjunctivitis?
You're really looking for the absence of two key features: significant pain and significant vision loss. The core symptom profile of a true uncomplicated conjunctivitis is generally more about discomfort, a gritty feeling like sand in the eye, maybe some burning, obvious redness, watering, perhaps some discharge. But crucially, no severe deep aching pain and vision should be broadly okay, maybe slightly blurry from discharge but clearing with blinking.
Right.
If they report severe pain, like a deep ache inside the eye, or if their vision is suddenly noticeably blurred or lost, you absolutely have to stop, take a step back, and immediately run through your mental checklist to rule out the 3 acute red eye causes that demand urgent action.
And those 3 are?
Acute angle closure glaucoma, uveitis, specifically anterior uveitis, and a penetrating foreign body or significant corneal abrasion. Those are the big 3 you cannot miss.
Okay, let's assume for now we're fairly confident it is conjunctivitis. We need to delve into the 5 distinct types, starting with the very common viral conjunctivitis, often caused by adenovirus. How does this typically present, and what's the usual course?
Right. Viral is probably the most common overall. It's typically characterized by excessive watering, often described as intensely watery, maybe with a little bit of mucus mixed in, but not frank pus, and often quite significant light sensitivity, photophobia.
And it spreads like wildfire, doesn't it?
Oh, it's highly contagious, usually spreads through direct contact or contaminated surfaces. It's really important to reassure the patient that this is almost always self-limiting. It'll usually resolve on its own over 1 to 2 weeks, much like a common cold runs its course.
So, given how contagious it is, what's the absolute cornerstone of management advice?
Management is purely supportive, really. Cool compresses can help soothe the eye. But critically, it's all about strict hygiene advice. Separate towels for the affected person, meticulous hand washing before and after touching the face or eyes, and trying to avoid sharing pillows, flannels, anything like that.
What about school or work exclusion?
Interestingly, in the UK, current guidelines suggest that viral conjunctivitis does not typically require automatic school or work exclusion, unlike bacterial if it's weeping profusely. However, we absolutely must counsel patients and families strongly on the high risk of contagion and the importance of those hygiene measures.
And when would you refer?
We'd typically refer if it hasn't started to show definite signs of improvement within about 7 to 10 days. Or, importantly, if you suspect recurrent episodes, especially in the same eye, because that might raise the suspicion of underlying herpes simplex virus keratitis, which needs specific antiviral treatment.
Okay. Next up, the one everyone sort of expects and often wants to treat, bacterial conjunctivitis. What's the real clinical giveaway here compared to viral?
The absolute giveaway is the consistency of the discharge. Bacterial conjunctivitis, usually caused by common bacteria like Staphylococcus aureus or Streptococcus pneumonia, is defined by thick, purulent discharge, frank pus.
Yellowy green gunk.
Exactly. And that characteristic crusting, particularly bad upon waking in the morning, sometimes literally cementing the eyelids shut. That's bacterial until proven otherwise.
Right. Now, this is where the antibiotic prescribing strategy is really crucial, both for good practice and for the AKT. We know it's usually self-limiting, often within 5-7 days, even without treatment, but we frequently end up prescribing. What's the responsible, high-yield approach here?
Yeah, this is key. While we have effective topical antibiotic options, chloramphenicol drops or ointment are very common first-line choices. Azithromycin drops have better dosing convenience. Fusidic acid is good for Staph aureus. The gold standard approach in primary care for most mild to moderate cases is often actually a delayed antibiotic prescription.
Explain how that works.
You basically assess the patient, explain the likely diagnosis, emphasize the self-limiting nature, strongly advise on lid hygiene, like bathing away the crusting with cooled, boiled water. Then you give them the prescription, but advise them. Try just the cleaning and maybe some artificial tears for the next 48 to 72 hours. If there's absolutely no sign of improvement by then go ahead and start the antibiotic drops.
And the rationale.
It avoids unnecessary antibiotic use in many cases that would have resolved anyway, helps combat resistance, and manages patient expectations appropriately. We'd really only consider swabbing the discharge for culture and sensitivity if the initial treatment fails, or perhaps if the case is very severe from the outset or recurrent, where knowing the specific bug and its sensitivities becomes important.
That's a really practical clinical nugget, showing that knowledge of responsible prescribing. Okay, moving on to allergic conjunctivitis. The symptoms here are probably the easiest to distinguish, aren't they?
Yes, I think so. The absolute classic symptom profile for allergic, which is typically an IgE-mediated type 1 hypersensitivity reaction, is intense bilateral itching. Itching is the dominant feature.
They just want to rub their eyes constantly.
Exactly. Along with redness, maybe some swelling of lids, chemosis, and often some stringy, watery discharge. And crucially, it's often strongly linked to other atopic conditions. Think asthma, eczema, allergic rhinitis, or hay fever. They'll almost always be able to identify specific triggers too, like pollen in the summer, dust mites, animal dander.
So how do we manage that intense itching, which is the main complaint?
Management is really multi-pronged. Allergen avoidance is obviously key if the trigger is known. Symptomatically, the first line is usually topical antihistamine drops, which provide rapid relief. For patients with predictable seasonal patterns or more chronic symptoms, we might step up to using mast cell stabilizers prophylactically, like sodium carbobucade or nitochromonyl sodium. These take a couple weeks to work fully, but help prevent the mast cells releasing histamine and other inflammatory mediators in the first place.
Right, prevention is better than cure there. Okay, type 4 on our list. Irritant conjunctivitis. This sounds like a bit of a catch-all category, but it's the one that most frequently requires us to pull out that fluorescein dye again, isn't it?
Precisely. Irritant conjunctivitis covers anything caused by direct irritation to the eye surface. Think chemical splashes, acids, alkalis, even household cleaners. Or severe dry eye disease itself can cause an irritant picture. Or sometimes a persistent, maybe tiny foreign body trapped under the eyelid, constantly rubbing the surface.
So fluorescein is key.
Absolutely. The core diagnostic step here is using fluorescein to determine if the irritant has actually caused an abrasion or significant corneal epithelial damage. Management then focuses logically on removing the source of irritation, copious irrigation immediately for chemical splashes, finding and removing any foreign body. And crucially, advising patients who wear contact lenses to stop wearing them completely until the eye has fully settled and any staining has resolved.
Makes sense. Finally, we circle back to the one real emergency within this conjunctivitis group, ophthalmia neonatorum.
Yes, this one stands apart. It's a devastating diagnosis, potentially, and it warrants the absolute highest degree of urgency. It's defined simply as any conjunctivitis occurring within the first 4 weeks of life.
And the big worry is infection acquired during birth.
Exactly. While it can sometimes be non-infectious, maybe chemical irritation from prophylactic drops given at birth, the major concern is the infective causes, particularly Neisseria gonorrhea or Chlamydia trachomatis, acquired from the mother's genital tract during delivery. An untreated gonococcal infection in particular can rapidly progress to corneal ulceration, perforation, and potentially permanent blindness within days.
So the management is?
No messing about. This presentation demands immediate, same-day, urgent ophthalmic referral. They need urgent assessment, conjunctival swabs sent for microscopy and culture, including specific testing for gonorrhea and chlamydia, and prompt initiation of appropriate systemic antibiotic treatment, often as an inpatient. This cannot wait.
Oh, wow. Okay. So what's really fascinating here, just looking back over those 5 types, is how the type of discharge, watery, purulent, maybe stringy, combined with the key accompanying symptoms like itching, or crucially the presence or absence of severe pain, allows us to rapidly filter through 5 quite separate diagnoses. If we don't master this section, we're going to miss the common stuff constantly, and worse, we risk missing that rare but critical neonatal emergency.
Absolutely. Getting conjunctivitis straight is fundamental.
Okay, let's pivot slightly from the conjunctiva itself to the structures that surround and protect it, the eyelids. Chronic inflammation of the lids, or blepharitis, is incredibly common and can cause massive frustration for patients, can't it?
Oh, hugely frustrating. Blepharitis is probably the most frequently encountered chronic eyelid issue we see. It's defined simply as chronic bilateral inflammation right along the eyelid margins. And patients often notice it significantly worse first thing in the mornings.
Where is that?
It's thought to be due to tear film evaporation and stagnation overnight, allowing inflammatory mediators and bacterial toxins to build up along the lid margin while the eyes are closed.
And it often seems to coexist with other more systemic skin conditions, right?
Yes, there are quite strong associations, particularly with generalized skin issues like seborrheic dermatitis, dandruff and greasy skin, and also with acne rosacea. This link is important because it confirms that blepharitis is often a chronic inflammatory management issue tied into underlying skin health and gland dysfunction, not just a simple one-off infection you can clear with a short course of antibiotics.
What are the classic symptoms patients complain of?
The symptoms are pretty classic. That gritty, foreign body sensation again, maybe some burning, chronically crusty, or sometimes greasy-looking eyelids, mild chronic redness along the lid margins, and often a propensity for recurrent styes or chalasia because the glands are getting blocked.
Right. So if the underlying problem is this chronic inflammation and blockage of the little meibomian glands in the eyelids, the management has got to be focused on a long-term routine, not just a quick fix, presumably.
Exactly. You have to manage patient expectations here.
What is the absolute cornerstone of blepharitis management that we need to hammer home?
The core treatment, and this really needs to be stressed to the patient repeatedly, is diligent, lifelong eyelid hygiene combined with regular warm compresses. That's the foundation.
How does that work practically?
We instruct patients to use a warm compress like a clean flannel soaked in warm water or one of those microwavable eye masks held gently against the closed eyelids for about 10 to 15 minutes. This helps to melt the solidified oils, the sebum, within the blocked meibomian glands. And then immediately after the warm compress, they need to do gentle massage of the eyelids towards the lashes, or use specific lid scrubs, or even just diluted baby shampoo on a cotton bud to mechanically clean away the melted secretions, debris, and crusts from the lid margin and lash roots. This needs doing at least once, preferably twice, a day, every day, potentially forever.
What about medications?
Pharmacologically, we might use topical antibiotics like chloramphenicol ointment applied to the lid margins for a couple of weeks, but that's usually only reserved for flare-ups where there's clear secondary bacterial infection. For more severe posterior blepharitis, especially if it's associated with rosacea, sometimes a longer course of oral tetracycline antibiotics, like doxycycline, is used, acting more as an anti-inflammatory than an antibiotic in that context. Artificial tears can also help with associated dry eye symptoms.
Okay. Now, for the AKT specifically, we always need to know the red flags, the reasons why you'd need a same-day referral to ophthalmology, even for something as common and chronic as blepharitis. What are they?
The same-day referral criteria for blepharitis are fairly straightforward but absolutely critical to know. Number one, any associated visual loss or acute deterioration in vision that the patient reports, that's always a red flag.
Right.
Number two, any suspicion of associated corneal disease. So if the patient has significant pain, photophobia, or you see staining with fluorescein, that needs urgent assessment.
Okay.
And number three, any signs of the inflammation spreading beyond the lid margin, suggesting a more serious infection like perceptal or even orbital cellulitis, swelling, redness extending onto the cheek, pain with eye movements, that's an emergency.
Got it. Okay, now let's tackle that famous pair of lumps and bumps on the eyelid. The chronic, firm chalazion versus the acute, painful sty. Getting this differentiation right often dictates the immediate management plan.
Yeah, this is a classic differential diagnosis scenario you'll definitely encounter. So a chalazion, which is also known as a meibomian cyst, results from a chronic blockage of one of the meibomian oil glands within the eyelid. This blockage leads to leakage of oil into the surrounding eyelid tissue, causing a sterile chronic inflammatory reaction, essentially forming a little granuloma.
And how does that present?
It typically presents as a firm, usually non-tender, or perhaps only minimally tender, smooth, roundish swelling within the eyelid itself, often feeling quite deep and frequently in the upper lid. The key phrases are firm and chronic. It develops slowly over weeks or months. And again, the risk factors include underlying chronic blepharitis and rosacea, which predispose to gland blockage.
Okay, firm and chronic. And the initial management of a chalazion is purely conservative, isn't it?
Exactly. Because it's sterile inflammation, not infection, antibiotics aren't helpful initially. We really hammer home the importance of those intensive warm compresses again, maybe 10 minutes at a time, trying for 4 or 5 times a day if possible, followed by gentle massage over the lump towards the lid margin. The aim is to try and melt the contents and encourage drainage.
When would you refer a chalazion?
Referral to ophthalmology for potential incision and curettage is usually only considered if the lump persists despite a good month or 2 of conservative treatment, if it's recurrent in the same spot, which might raise suspicion of malignancy, although rare, or if it becomes very large and starts mechanically pressing on the cornea, causing blurred vision or astigmatism.
Okay. Now, contrast that chalazion with a sty or hordeolum. How's that different?
The sty is completely different in its pathology and presentation. A sty is an acute, localized bacterial infection, usually Staphylococcus aureus, again, typically affecting either one of the smaller glands at the base of the eyelashes, the glands of Zeiss or Moll, that's an external sty or hordeolum externum, or occasionally a meibomian gland itself, an internal sty, hordeolum internum.
And the key difference symptomatically?
The defining characteristic is pain and acute onset. It's essentially a small abscess or boil on the eyelid margin. It will be red, swollen, tender, and come up quite quickly over a day or 2. These are generally self-limiting. Like a pimple, they often point, develop a yellowhead, and then drain spontaneously within a week or so. Warm compresses can help speed this up. Topical antibiotics might be used if it's discharging heavily, but often aren't needed unless there's significant surrounding cellulitis developing.
So chalazion, chronic, firm, non-painful granuloma, STI, acute, painful, localized infection abscess.
That's the key distinction.
Got it. We should also probably briefly cover the malpositioning issues of the lids. Entropion and ectropion, just the basics.
Yeah, quickly. These are often age-related changes due to lid laxity, but can also be caused by scarring. Entropion is where the eyelid margin, usually the lower one, turns inward. The problem here is that the eyelashes then constantly rub against the sensitive cornea and conjunctiva, a condition called trichiasis. This causes irritation, watering, and can lead to corneal abrasions or ulcers. Management involves lots of lubricants initially, maybe taping the lid down, but often requires surgical correction to turn the lid back out and prevent corneal damage.
And ectropion.
Ectropion is the opposite. The eyelid margin turns outward, again, usually the lower lid. This leads to poor tear drainage down the punctum, causing excessive tearing, epiphora, and also chronic exposure and drying of the conjunctiva and cornea. Again, management starts with lubricants to protect the eye surface, but surgical tightening of the lid is often needed if symptoms are significant.
Okay. To sort of round out the section on lids and surface issues, let's briefly look at common surface growths and also the whole issue of dry eyes versus excessive tearing, linking them back to our overall triage principles.
Right. Surface growths on the conjunctiva are usually benign, but you need to know the difference between the two common ones. A pinguecula is a very common, slightly raised, yellowish, fleshy-looking degenerative nodule. Crucially, it sits on the conjunctiva, typically in the horizontal meridian near the cornea, but it does not grow onto the cornea itself. It's usually asymptomatic or might cause mild irritation, managed primarily with lubricants if needed. No treatment is usually required.
And the other one?
The other one is a pterygium. This was more like a triangular, fleshy, vascularized, you can see blood vessels in it, wedge-shaped growth that starts on the conjunctiva, but critically does grow across and encroach onto the surface of the cornea.
Ah, so it invades the cornea.
Yes. Pterygia are strongly associated with chronic UV light exposure, hence sometimes called surfer's eye. They need more careful monitoring because if they grow far enough across the cornea, they can start to distort vision by inducing astigmatism or eventually grow right across the pupil, obstructing vision. They may need surgical excision if they become symptomatic or threaten the visual axis. Lubricants help with irritation.
Okay. And then the huge topic of dry eye syndrome, or keratoconjunctivitis sicca.
KCS.
Yes, this is a massive area in ophthalmology and primary care. It causes chronic bilateral irritation, grittiness, burning, sometimes paradoxically watery eyes, and fluctuating blurry vision. The causes are numerous. Simply aging is a big factor, reduced blinking frequency, like hours spent staring at a computer screen, underlying blepharitis disrupting the tear film's oily layer, certain medications, antihistamines, diuretics, and importantly, systemic autoimmune conditions like Sjogren's syndrome or rheumatoid arthritis.
Is there a specific diagnostic test we should know for the exam?
The definitive objective diagnostic tool, especially the one often cited in exams, is the Schirmer's test. This involves placing a small strip of special filter paper hooked over the edge of the lower eyelid for 5 minutes and measuring the amount of wetting on the paper in millimeters. It directly measures basal and reflex tear volume production. Less than 5 millimeters of wetting in 5 minutes is generally considered indicative of significant aqueous tear deficiency. Right. Now, flipping that coin, what if a patient presents not with dry eye, but with sudden excessive tearing lacrimation? This seems like the opposite problem, but which urgent diagnoses should still be on our differential list, forcing us back to red flag thinking.
That's a great point. While simple things like a corneal abrasion, a superficial foreign body, or even a blocked tear duct, nasolacrimal duct obstruction, are common causes of excessive watering or tearing, epiphora, if the tearing is acute, perhaps unilateral, and especially if accompanied by significant pain or vision change, it must force us back to considering those red flag conditions again.
Yes.
Think, could this be anterior uveitis causing reflex tearing due to pain and inflammation? Could it be acute angle closure glaucoma, where the high pressure causes corneal edema and irritation leading to tearing? Or could it be a penetrating injuries or a high-velocity foreign body causing intense irritation? The eye often produces excess tears as a defensive mechanism in response to significant pain or irritation. So if the tearing is really dramatic and acute, the underlying stimulus might well be serious. Don't just assume it's a blocked duct without considering the alternatives.
Okay, let's shift our focus now towards pediatric and developmental ophthalmology, specifically looking at squint or strabismus. This is such a critical diagnosis to make in childhood because of the potential for permanent visual impairment if it's missed.
Absolutely critical. Strabismus simply means a misalignment of the visual axes of the two eyes. They're not pointing at the same spot at the same time. It can be categorized by the direction of the turn. Esotropia is an inward turn, cross-eyed. Exotropia is an outward turn. And hypertropia or hypotropia refer to vertical misalignment, one eye higher than the other.
Is it always abnormal?
Well, it's worth remembering that intermittent fleeting squinting is actually quite common and considered benign in very young neonates, perhaps up to about 4 to 6 months of age, as their visual coordination is still developing. However, a persistent misalignment noted in an older baby or child is always a major red flag and needs investigation.
Now, what's the fundamental difference in the consequence of strabismus if it presents in a young child versus an adult? This feels like a really key insight for understanding why early detection is vital.
This is probably the definitive point about childhood strabismus for the AKT. In an adult who develops a squint suddenly, maybe due to nerve palsy, their fully developed visual system receives two conflicting images from the two eyes pointing in different directions. The brain can't fuse these, resulting in diplopia double vision. The adult is usually acutely aware that something is wrong.
Right, they'll complain of seeing double.
Exactly. But in a young developing child, typically under the age of about 7 or 8, the brain has this remarkable plasticity. To avoid the confusion and distress of double vision, the brain automatically learns to actively suppress or ignore the visual input coming from the misaligned eye.
It just switches it off, effectively.
It effectively switches off the processing of that image. This suppression, if it continues throughout the critical period of visual development, leads directly to amblyopia, commonly known as lazy eye. Amblyopia is defined as reduced visual acuity in one or sometimes both eyes, for which no anatomical cause, like a cataract or retinal scar, can be found on examination. The eye itself is healthy, but the brain pathways haven't developed properly due to lack of use.
And the scary part is, if that amblyopia isn't detected and treated before that critical visual development window closes roughly around ages 7 to 9, the vision loss becomes largely permanent.
That's the tragedy we're trying to prevent. The childs won't complain because they've never known anything different, but they could end up with permanently poor vision in one eye.
So the whole goal of childhood vision screening programs and managing strabismus is essentially to prevent amblyopia by forcing the brain to use the weaker eye. What are the identifiable risk factors we should look for that might make a child more likely to develop strabismus?
Known risk factors include prematurity or low birth weight, a positive family history of squint or amblyopia, the presence of significant uncorrected refractive errors, particularly moderate to hypermetropia, longsightedness, is strongly linked with esotropia.
Ah, interesting link back to refractive errors.
Yes, the effort of focusing can trigger the inward turn. And there's even some evidence linking maternal smoking during pregnancy to an increased risk. So a careful history is important. Assessment is obviously key too.
What's the standard assessment maneuver that we should be familiar with performing or interpreting results from in primary care?
Well, after a general neurological check, the standard clinical test for detecting strabismus is the cover-uncover test.
How does that work?
You have the child fixate on a target, say a toy or a light. You then cover one of their eyes and carefully observe the other, uncovered eye for any movement. If that uncovered eye has to move, e.g. moves outwards, to take up fixation when the other eye is covered, that indicates it must have been turned inwards esotropic beforehand. You then repeat by covering the other eye. You also do the uncover part, watching the eye you just uncovered to see if it drifts back out of alignment. It allows you to detect both manifest squints, tropias, and latent squints, phorias.
And the management pathway.
Any child with a suspected persistent squint needs a routine referral to pediatric ophthalmology or a community orthoptic service. The only exception would be if there are associated red flag neurological signs, things like acute onset squint, double vision in an older child, headache, abnormal head posture, nystagmus, or limited eye movements, especially abduction suggesting a possible sixth nerve palsy, which might suggest an underlying neurological cause, warranting a potentially more urgent pediatric neurology referral first.
And the ophthalmology management itself focuses on correcting the issue before amblyopia becomes permanent.
Exactly. Step one is always to check for and correct any significant refractive error with glasses, as sometimes that alone fixes the squint, accommodative esotropia. Then, the mainstay of treating any associated amblyopia is occlusion therapy, patching the good eye for a prescribed number of hours each day. This forces the brain to use the weaker amblyopic eye and helps the visual pathway develop.
The classic eye patch.
The classic eye patch. Other options include penalization, using atropine drops in the good eye to blur its vision, making the child preferentially use the amblyopic eye. And if glasses and patching don't fully correct the misalignment itself, then surgical correction of the eye muscles might be considered later, or sometimes injections of botulinum toxin into the eye muscles for certain types of squint.
Okay, important area.
Yeah.
We should also probably just quickly mention the Ishihara chart, those colored dot plates, as the standard method for testing color vision deficiency.
Yep, the Ichihara plates are used to screen for red-green color blindness, which is important to know is primarily an X-linked recessive condition.
Meaning it almost exclusively affects males.
That's right, much rarer in females.
Okay. Now here's where it gets, as I said before, really interesting and frankly quite detailed for those preparing for the AKT, the objective thresholds for registering someone as visually impaired in the UK. This isn't just common sense. It requires knowing specific Snellen acuity numbers and understanding descriptions of visual field loss. We have two main categories of registration, don't we?
Yes, and knowing these precise numerical criteria is absolutely essential, not just for exams, but because registration unlocks access to vital social support, benefits, and rehabilitation services for patients. You need to be able to identify who qualifies. We start with the more severe category. Severely sight-impaired, SSI, which used to be known and is still often referred to by patients as being registered blind.
Right. Can you detail the three distinct criteria pathways that can lead to SSI registration? It's not just about acuity, is it?
No, it's a combination of visual acuity, VA, and visual field assessment. There are essentially three ways to qualify for SSI.
Primarily based on acuity. This is the most straightforward. Their best corrected VA in their better eye is less than 360 Snellen. So they can only read the top letter at 3 meters, whereas someone with normal vision could read it way back at 60 meters.
Very poor central vision.
Very poor, yes. Pathway 2. Based on intermediate acuity plus significant field loss. Here, their VA might be a bit better, say up to, but not including 660, so maybe 360, 460, 560. But they also have a severely contracted visual field. The definition is nuanced, but essentially very significant tunnel vision.
So even if they can see a bit more centrally, their periphery is gone.
Exactly. And pathway 3. Based on relatively better acuity but extreme field loss. This is perhaps the trickiest one. Their VA might actually be better than 660, example 636 or even 624, but they have a grossly constricted visual field or a field defect that causes disabling functional impairment. The classic example given is something like a complete bitemporal hemianopia, loss of both outer halves of vision from a pituitary tumor, or extremely severe tunnel vision from advanced glaucoma.
So the key takeaway there is that even if your central Snellen acuity seems relatively okay on the chart, having devastating visual field loss can still qualify you for the highest level of registration, SSI or blind.
Absolutely. Functional vision is about both acuity and field.
Okay. Now, what about the less severe but still very impactful category, sight-impaired, SI, which used to be called partially sighted? What are the thresholds for that?
Right. For SI registration, the thresholds are, as you'd expect, slightly less restrictive, reflecting a lower but still significant level of visual impairment. Again, there are several pathways.
Low acuity range plus field loss. This covers VA falling between 360 and 660, so better than SSI threshold but still poor, combined with some degree of associated visual field loss.
Moderate acuity range plus moderate field loss. Here, the VA is better again, typically between 660 and 624, alongside what's described as a moderate contraction of the visual field.
Relatively good acuity, but marked field defect. This is similar to the third SSI category, but less severe. Their VA might be only slightly reduced, perhaps better than 618 in some cases, but they have a marked visual field defect that significantly impacts function. For example, a large homonymous hemianopia, loss of one side of vision in both eyes after a stroke.
So again, that interaction between the acuity number and the extent and nature of the visual field defect is absolutely crucial for determining registration category.
It's the crucial takeaway. You can't assess eligibility based on just the Snellen chart alone. It dictates the entire prognosis, rehabilitation potential, and the support pathway available to that patient. Knowing these numbers is key for advocating for your patients.
Okay, we've deliberately saved the true ophthalmic emergencies, the conditions causing that acute red eye that require phone calls, not just prescriptions, for this final section. Let's start with uveitis.
Right, uveitis is, by definition, inflammation of the uveal tract. Now, the uveal tract is the middle pigmented vascular layer of the eye. It's got three parts: the iris at the front, which controls pupil size, the ciliary body just behind it, which controls accommodation and produces aqueous fluid, and the choroid further back, which nourishes the retina.
So inflammation can affect different parts.
Exactly. You can have anterior uveitis, uveitis or iridocyclitis, intermediate uveitis, posterior uveitis, or canuveitis, affecting all parts. We also classify it based on duration, acute being typically less than 3 months, chronic being longer. But what's really fascinating and clinically vital about uveitis is how often it acts as a mirror, reflecting significant underlying systemic pathology.
How does it link back to systemic disease? This sounds important.
Hugely important. While uveitis can certainly be idiopathic, no known cause, or caused by direct trauma to the eye, or even rarely be neoplastic masquerade syndromes, a very large proportion, especially recurrent or bilateral cases, are directly linked to underlying autoimmune or inflammatory disorders. Think particularly of the seronegative spondyloarthropathies.
Like ankylosing spondylitis?
Exactly. Ankylosing spondylitis is the classic association with acute anterior uveitis. Also reactive arthritis, or Reiter syndrome, psoriatic arthritis, inflammatory bowel disease, Crohn's, ulcerative colitis. Other key associations include connective tissue diseases like sarcoidosis, Behçet's disease, and infections like TB, syphilis, Lyme disease, or herpes viruses. So recognizing uveitis, especially in a new patient, can genuinely be the very first clue to an undiagnosed, potentially serious systemic inflammatory condition.
That's a powerful link. Okay, so when a patient presents with acute anterior uveitis, the symptoms are often that classic painful red eye and blurred vision, maybe some photophobia. But is there a specific high-yield pupillary sign we should look for that helps differentiate it from, say, acute glaucoma?
Yes, there is a key differentiating sign. In typical acute anterior uveitis, the specific sign we often look for is a miotic or small pupil in the affected eye.
Small pupil, why is that?
The inflammation within the iris and ciliary body causes spasm of the ciliary muscles, which pulls the iris inwards, resulting in that constricted pupil. It might also be slightly irregular in shape due to inflammatory adhesions forming, posterior synechia. Patients might also complain of flashes and floaters if there's associated inflammation further back to the vitreous, intermediate, or posterior uveitis.
And the management is urgent referral.
Absolutely. Uveitis is always an urgent, same-day referral to ophthalmology. Treatment typically involves intensive topical steroids, like Predforte or Maxidex, to quell the inflammation, often cycloplegic drops, like cyclopentolate or atropine, to dilate the pupil, relieve the ciliary spasm, which helps with pain, and prevent those adhesions forming. And of course, investigating and managing any underlying systemic cause is crucial, potentially involving rheumatology and long-term immunosuppressants in chronic cases.
Okay, uveitis, painful, red, often small pupil, think systemic disease, urgent referral. Got it. Now let's tackle the other big red eye emergency, glaucoma. We need to be clear that it's not just about high pressure in the eye, is it? It's fundamentally about optic nerve damage.
That's the crucial modern understanding. While high intraocular pressure, IOP, is the main risk factor we can treat, glaucoma itself is defined as a progressive optic neuropathy, meaning damage to the optic nerve head, which leads to a characteristic pattern of irreversible visual field loss. We need to clearly define the spectrum.
So what are the stages or types?
We can think of a spectrum. First, you have ocular hypertension, OHT. This is simply defined as consistently elevated IOP, usually greater than 21 mAhg, but, and this is the key bit, with no detectable damage yet to the optic nerve head, no disc cupping, and no visual field loss on testing. It's a risk factor for developing glaucoma, not glaucoma itself.
Okay, high pressure but healthy nerve.
Exactly. Then you have glaucoma proper. This is where that raised IOP, or sometimes other factors, is causing progressive damage to the optic nerve fibers as they exit the eye at the optic disc, leading to characteristic cupping of the disc and measurable irreversible loss of peripheral vision initially. And critically, we must remember that this glaucomatous optic nerve damage can sometimes occur even at statistically normal pressures. That's called normal tension glaucoma, NTG. Pressures isn't the whole story, though it's the main thing we target.
Okay, let's focus then on the two main clinical presentations of glaucoma, starting with the much more common, insidious one, primary open-angle glaucoma, POAG.
Right. Open-angle glaucoma is the chronic, slowly progressive form, and it's by far the most common type, especially in older populations. The angle refers to the drainage angle in the front of the eye, between the iris and the cornea, where the aqueous fluid drains out through the trabecular meshwork. In open-angle glaucoma, this angle is anatomically open. It looks normal, but the trabecular meshwork itself just isn't draining fluid efficiently enough over time.
So the pressure gradually creeps up.
Exactly. The pressure gradually rises, usually over years. This condition is typically bilateral, although often asymmetrical. And crucially, it is almost always completely painless and asymptomatic in the early stages. The vision loss it causes starts way out in the periphery of the visual field, creeping inwards very slowly. Because central vision is spared until the very late stages, the patient often doesn't notice anything is wrong until severe, irreversible damage has already occurred, resulting eventually in that characteristic tunnel vision.
That sounds incredibly dangerous because it's so silent. Who are the high-risk groups we should be particularly vigilant about screening?
It's dangerous precisely because it's painless and insidious until it's too late. High-risk groups we absolutely need to know include patients over 40, risk increases significantly with age; those of Black, African, or Afro-Caribbean descent, who have much higher prevalence and often more aggressive disease; patients with high myopia, short-sightedness; anyone with a first-degree relative with glaucoma, strong genetic component; and importantly, linking back to systemic health, those with significant systemic vascular risk factors like diabetes and hypertension, and also patients on long-term systemic or potent topical steroid use.
Interesting link to vascular factors and steroids.
Yes, it's thought that poor perfusion of the optic nerve head might play a role, especially in normal tension glaucoma, and steroids are well known to increase IOP in susceptible individuals.
What's the primary care role in managing diagnosed POA? Are we starting treatment?
Generally, diagnosis and monitoring are done by ophthalmology optometry using regular IOP checks, optic disc imaging, and visual field testing. However, GPs are often involved in prescribing the long-term treatment. The first-line medical therapy is usually prostaglandin analog eye drops like latanoprost, travoprost, or bimatoprost. These are typically used just once daily, usually at night, and work by increasing the outflow of aqueous fluid from the eye.
And if they're not enough?
If prostaglandin analogs alone aren't sufficient to lower the IOP to the target level, or if they're not tolerated, the next step is often adding or switching to a topical beta blocker drop, like timolol, used twice daily. These work differently, by reducing the production of aqueous humor by the ciliary body. Other options exist too, alpha agonists, carbonic anhydrase inhibitors, but prostaglandins and beta blockers are the mainstays. Laser trabeculoplasty or surgery might be needed if drops fail.
Okay, so POAG equals chronic, painless, peripheral field loss, tunnel vision, managed long-term with drops. Now we move to the absolute opposite end of the spectrum, the true, blinding, ophthalmic emergency. Acute angle closure glaucoma, AACG. This is acute, it's painful, and it requires immediate hospital admission.
Absolutely. Acute angle closure glaucoma is a dramatic, mechanical, painful crisis. It happens when the drainage angle, that space between the iris and cornea, physically narrows or closes off completely, usually because the iris bows forward and blocks the trabecular meshwork. This stops aqueous fluid from draining out, causing an abrupt, massive, and dangerous spike in intraocular pressure, often up to 50, 60, 70 millimol Hg or even higher, very quickly.
What makes someone susceptible to this? Who's at risk?
The main risk factors are anatomical. People with hypermetropia, long-sightedness, tend to have smaller eyes and shallower anterior chambers, making the angle naturally narrower and more prone to closure. Increasing age is also a risk factor, as the natural lens inside the eye grows thicker over time, pushing the iris forward. Certain ethnicities, particularly East Asian populations, have higher rates. And the classic textbook trigger for an acute attack is pupillary dilatation.
Why dilation?
Because when the pupil dilates, the iris tissue bunches up peripherally, thickening it and making it more likely to press against and block the drainage angle, especially if the angle is already narrow. This is why the classic scenario often described as someone developing ACG after walking from a bright environment into a dark one, like a cinema hall, causing natural pupil dilation. Or sometimes it can be triggered iatrogenically by using dilating eye drops, mydriatics, in someone with predisposed narrow angles, which is why checking angles before dilation is important.
Okay. The clinical presentation of ACG must be absolutely memorable for the AKT. How does this patient look and feel when they present?
The presentation is usually incredibly dramatic and distressing for the patient. They report a very painful red eye, often described as a severe, deep, boring ache. The pain can be so intense that it triggers systemic symptoms like nausea and vomiting, which can sometimes actually mislead a clinician away from the eye diagnosis, making them think it's maybe a migraine or a gastrointestinal issue.
That's a key pitfall.
A very key pitfall. Vision in the affected eye is usually severely blurred or decreased, often described as steamy or hazy. And upon gentle palpation of the closed eyelid, if possible might be too tender, the eye often feels rock hard classically compared to a marble due to that intense internal pressure.
And what are the defining clinical signs we must look for on examination? The things that clinch the diagnosis.
The absolute pathognomonic triad of signs you must look for is, number one, a hazy, edematous, steamy-looking cornea. This is due to the very high pressure forcing fluid into the corneal layers. Number two, the patient often reports seeing halos or rainbows around lights. This is also due to the corneal edema scattering light. And number three, most importantly and distinctively, the pupil will characteristically be oval-shaped, fixed in mid-dilation, around 4-6 millimeters, and non-reacting or very sluggishly reactive to light.
Not small like in uveitis, but fixed and mid-dilated.
Exactly. That combination, severe pain, hazy cornea, fixed mid-dilated pupil, screams acute angle closure glaucoma and mandates immediate same-day emergency transfer to the nearest ophthalmology department. This is sight-threatening within hours if not treated.
What is the immediate medical management that might be initiated, perhaps even in A&E or by paramedics, to try and reduce that dangerously high pressure while awaiting specialist input?
The absolute priority is getting that IOP down fast. Medically, this usually involves giving acetazolamide, which is a carbonic anhydrase inhibitor. It can be given orally, PO, or sometimes intravenously for faster action. It works by significantly reducing the production of aqueous humor.
Okay.
Topically, they'll often administer pilocarpine eye drops. Pilocarpine is a miotic, constricts the pupil. In angle closure, the aim is that by constricting the pupil, it pulls the peripheral iris away from the drainage angle, helping to physically reopen it. Other pressure-lowering drops like topical beta blockers, Rigi, Timolol, might also be used concurrently. Strong analgesia and antiemetics are usually needed too.
But the definitive treatment isn't drops, is it?
No, the definitive treatment to relieve the angle closure itself and prevent recurrence is usually surgical, most commonly a laser peripheral iridotomy, LPI. This involves using a laser to create a tiny hole in the peripheral iris, which allows aqueous fluid to bypass the blocked angle and flow out, relieving the pressure gradient. This is usually done urgently once the initial pressure spike and corneal haze have settled with medical treatment. They'll often do a prophylactic LPI in the other eye too, as the condition is often bilateral eventually.
Okay, a real emergency pathway there. Finally, just to wrap up the whole glaucoma picture, what are the 3 key investigations that are mandatory for both diagnosing and monitoring glaucoma, whether it's open angle or after an angle closure event?
The essential triad of investigations for glaucoma are 1. Fundoscopy, specifically looking at the optic disc for signs of damage, like increased cupping, the cup-to-disc ratio, or neurofiber layer thinning. 2. Tonometry, which is the measurement of intraocular pressure, IOP. And 3. Perimetry, which is formal visual field testing, like a Humphrey visual field test, to map out the extent and pattern of any irreversible peripheral vision loss. These 3 tools together, looking at structure, disc, pressure, IOP, and function, field, are what define the diagnosis, staging, and monitoring of progression in glaucoma.
#outro.
So what does this whole deep dive into the anterior segment and red eye triage really mean for you, the GP trainee, listening and prepping for the AKT?
Well, I think it means you now hopefully have a much clearer, more structured approach to tackling that common presentation.
Yet your primary job, remember, is effective triage. You absolutely must master the differences between the common, mostly benign stuff. Viral conjunctivitis, think watery, gritty, maybe photophobia, usually self-limiting. Bacterial, think purulent discharge. Crusting, often self-limiting but considered delayed antibiotics. Allergic, think intense itching, bilateral, associated atopy. Get those straight.
But even more critically,
you need to instantly recognize the red flags for the emergencies. Uveitis, painful red eye, often a small or irregular pupil. Photophobia, always consider systemic links. And acute angle closure glaucoma, the very painful red eye, nausea, vomiting, hazy cornea, and that classic fixed mid-dilated pupil. Those need immediate action. And don't forget those precise visual impairment registration numbers for SSI and SI. They do come up. Plus, understanding the core danger of missing strabismus in children, leading to irreversible amblyopia.
absolutely.
Right.
We've really tried to lay the essential groundwork today, focusing on the eye's surface, the lids, the conjunctiva, and these acute front of eye emergencies. Next time, in part 2, we promise we're going deeper into the eye. We'll be moving into the posterior segment, covering really important conditions like retinal detachment, diabetic retinopathy, age-related macular degeneration, vascular occlusions, and other optic nerve pathologies. More urgent stuff, but also chronic conditions you'll manage long-term.
But before we leave you today, let's just quickly revisit that profound link between systemic disease and eye health, which we touched on particularly with glaucoma. We noted that things like hypertension and diabetes are significant risk factors for developing open-angle glaucoma, likely due to chronic vascular changes affecting the optic nerve's blood supply. Now, consider this for a moment.
Yeah.
The eye is literally the only place in the entire human body where you can directly visualize blood vessels, arteries, and veins and nerve tissue, the optic nerve head, completely non-invasively, just using an ophthalmoscope.
It's a unique window, isn't it?
It's an incredible window into the body's microvasculature and nervous system. So think about those tiny arterioles you see during fundoscopy in the retina. If those vessels are showing damage, maybe hypertensive changes like AV nipping or silver wiring, or diabetic changes like microaneurysms and hemorrhages, what does that inevitably imply about the state of the rest of your patient's microvasculature, particularly in crucial end organs like the brain, the heart, and the kidneys?
The pathology you diagnose just by looking in the eye is often a direct predictor, or at least a very strong indicator, of their global systemic vascular risk, isn't it?
Precisely. That connection, how systemic disease manifests in the eye and how eye findings predict systemic risk, is a theme we'll definitely be exploring further when we delve into the posterior segment in part 2. Something for you to mull over until then.